Good evening, one and all. I am Gauri Krishna and I welcome all of you to Magul. Magul is a 3-day event which is conducted in connection with the World AIDS Day. The theme for this year's World AIDS Day is Global Solidarity, Shared Responsibility. Before going into the session, we will just go through some statistics. As per the global summary of AIDS epidemic, the number of people living with HIV is 36.9 million as per 2017 statistics. Every year, 1.8 million people are newly infected. Around 940,000 deaths were recorded per year in 2017. And around 5,000 new cases are reported every single day. Contraceptives, abortions, safe sexual practices, sex education, consent, sexual health, family planning, homo and heterosexuality. All these topics are very familiar to all of us, isn't it? But do you think that this is the state of every single person in our country? As per phase 4 of National Family Health Survey, 70% of men and 80% of women in 13 states of our country did not know what safe sexual practices are and what sexual education is. This clearly brings into the limelight the ignorance that is still existing in the lives of many people of our country. On this World AIDS Day, we, the members of SIMSA Kerala, are here with Magul, which means acceptance in Urdu. And we are here to make our little contributions to get rid of the ignorance, the taboos, the myths, the stigma attached to these topics. In the coming 3 days, through our panel discussion and interactive webinars, we would like to bring in more awareness, talk about preventions, and most importantly, bring in more acceptance and tolerance amongst our family, our friends, and peers to freely discuss about these topics and normalize it. We hope we will be able to achieve these objectives in the coming days. Now, a few words about SIMSA. SIMSA stands for South Indian Medical Students Association. It is a consortium of, by, and for the medical students of South India. It was founded on 10th June 2020 by a group of passionate medical students who came to understand the need of more opportunities and exposure for South Indian medicos. This organization is recognized by the Government of India, and all healthcare students studying in any of the healthcare courses in any year of the degree are welcome to come forth and join us and work with us. Now, a few instructions about for today's session. Make sure that you fill both the pre and the post-event forms. The pre-event form is already put up in the WhatsApp group. The post-event form will only be put in the live chat. Please make sure that you fill it before leaving. Any questions for the speakers, it can be put in the live chat. Please note, certificates will be issued based on the pre and the post-event responses. The yellow box will now shift from mine to Leah Mary Paul. Over to you, Leah.
Good evening, distinguished guests of the day and my dear friends. It is my great pride and pleasure to welcome you all to our first session of the 3-day webinar series, Magul, conducted by the South Indian Medical Students Association, Kerala, in accordance with World AIDS Day 2020, ending the HIV/AIDS epidemic, resilience and impact. In the backdrop of the COVID-19 pandemic, which, according to experts, have delayed the WHO's target to improve the lives of people living with HIV, it is of immense significance that we, the future of our healthcare system, discuss the treatment of this devastating, life-threatening disease, often associated with extreme discriminating and stigmatization behavior from the society in various aspects, which is the aim of today's panel discussion. The art of treatment, a multidisciplinary and integrated approach to AIDS treatment. Eminent professionals from varied fields of medical expertise are joining us today as we look at the treatment and prevention of HIV/AIDS from a spectrum of different angles: the immunological aspect, the psychological impact, and much, much more. Without further ado, let me welcome our guests who are here today to help us develop a holistic approach to HIV/AIDS. I gladly welcome Dr. 𝗦𝗜𝗠𝗦𝗔, Dr. Kiran Kumar S., and Dr. Ashwath Kumar to today's panel discussion, the ART of treatment. Our first guest of the day, Dr. 𝗦𝗜𝗠𝗦𝗔, completed her MBBS from Government Medical College, Trivandrum, and did her MD Microbiology at the same college. Currently working as the Assistant Professor in the Department of Microbiology at Government Medical College, Kozhikode. She is also the ICTC Officer of Kozhikode since the last 7 years. We are extremely lucky to have you here today with us, ma'am. Over to you.
Okay, thank you, Leah. Thank you for inviting me here. Okay, I can start now, Leah. Hello.
Yes, ma'am. Yes, ma'am.
Okay. So, as Gauri said, the theme of 2020 World AIDS Day. We have been celebrating this World AIDS Day for the past so many years. But what I feel still, that is this time when I'm speaking to you, is that still the stigma, the social stigma among this community. Okay. So we have been celebrating for the past so many years that they'll celebrate World AIDS Day with so many programs, campaigns, still that stigma exists. So the real reason behind the stigma you have to discover, and I'd like to contribute some what important things. That is, what we are doing in our Calicut Medical College, that is Kerala, about HIV and also the different counseling and the treatment modalities that we are doing in our state. Okay. So I'd like to share my screen. Shall I do it now?
Yes, ma'am.
Okay. As you all know, that first case of HIV, and it was described from New York. I'm only telling about important point. As you all know, you're all medical students, so you'll be aware of all the points. First case of HIV or the AIDS that was described from New York, USA. That is in 1981. Okay, and this was followed by the isolation of HIV-1. You know that HIV is HIV-1 and HIV-2, and the isolation of HIV it was on 1983. That is from the Pasteur Institute, Paris. Okay. After that, there is the word AIDS that was given by the International Scientific Committee, and that is also in 1983. And the transition of AIDS that is by the heterosexual needs and by blood transfusion and mother to child transmission and also by blood transfusion. So these are some of the important means of getting transmission by mode of transmission. And next is the route of HIV transmission. You can see this diagram. What majority is 80% heterosexual growth, and the rest the blood transfusion and from mother to child, and also the drug users. Okay. This is the diagram of the route of HIV transmission. Then you all know that HIV is the retrovirus family. Okay. So what is the importance of this retrovirus? This viruses contains a unique enzyme that is known as the reverse transcriptase. Okay, and which directs the synthesis of DNA from viral RNA after it infects the host cell. So that is the importance of the retroviruses. It possesses the reverse transcriptase enzyme. So you all know that the HIV, it infects the CD4 cells in our body. So when it infects the CD4 cells, it and later on that will lead to infection of the AIDS. You know all the process. That means I'm not going into detail about the viral replication and all things. So after this, when it infects the body, there are so many changes which are taking place. Okay, there are so many after the replication, certain phases in which the person will go through. And according to this, we can classify this as one is the acute, that is the acute stage. After the virus infects the CD4 cell count, we pass through a stage known as the acute HIV disease or the acute retroviral syndrome. Okay. So in this stage, there are so many symptoms. That means just like a flu-like syndrome it will present, and this occurs after 3 to 6 weeks after the primary infection. Okay. So next stage is the asymptomatic stage. That means here, what after the virus attacks the CD4 cell count, what will happen is that what the body's immune system start responding. Okay. So what will happen? The CD4 cell count will come to normal, and the patient in this stage, that means there will be a clinical latency. And you please note that this is only a clinical latency and not a microbiological latency. Okay, microbiologically, the virus is actively multiplying. The virus is still inside our body, but there is a state of clinical latency. That means there will not be any symptoms at this stage. And in this stage, the patient, it can persist. Okay, that stage is variable. That means it can last from 10 years to few months or to few months to 10 years or beyond that. Okay, so that is the stage of asymptomatic stage. And after that, there are so many stages like persistent generalized lymphadenopathy stage. Then they will go to the stage of symptomatic HIV stage, and finally ending up in full-blown AIDS. Okay, that is AIDS. That is the final stage. So that is all about different stages. And this showed that is just to make aware that that is abstinence. That is abstinence from that is any friendship like relation when it's going through some sexual relations. That is abstinence from such relations. Then be faithful to your partner. These are all I got from the 𝗕𝗓𝒃, that means Kerala AIDS Control Society. So this and then use condoms. So in between, I'm saying all these things are information publics. Next is so there is deficiency virus. As I told, I mean that is the retrovirus, and not going case of that. And just about the what milestones I told you, discovered in 1981 and isolation in 1983, and after that and question mark, that is vaccine is still in trial, so not yet discovered. This is the fact sheet. Okay, this is the statistics, and I think Gauri said something about the statistics in the beginning, and you can see the different groups that is infected with HIV, and male sex workers, then IUD workers, then transgenders, migrants, and different statistics there. And this is the HIV epidemic. That is, you can see the general population, and in this general population, the bridging population is there. That is, the bridging population is the population which is responsible for transmitting the disease to the general population. Okay, that comes about a very small group. That is the bridging population. There may be the sex workers, then the other, that is IUD, that is drug users. All these are the bridging population responsible for the transmission of disease to the general population. And the next is very important, the goals target national control program of the organization. You know that the National AIDS Control Program organization is working, that is in India, and under this comes the SACS, that is State AIDS Control Organization. Okay. So in Kerala, it is known as Kerala, that is KESAC, that is Kerala AIDS Control Organization. So the target of National AIDS Control Program is by 2030 to end the epidemics of AIDS. Okay, that is one thing. Then on 2020, that is to eliminate the mother-to-child transmission of HIV and also syphilis. Syphilis is an STD, so by 2020, you should eliminate the transmission of HIV from mother to child. And by 2020, that is elimination of HIV-related discrimination by 2020, already 2020, but still I feel that the stigma exists. Okay, so this is the target of NACP. Okay, 2030 to end the epidemic of 20 to eliminate mother-to-child transmission, and by 2030 to eliminate HIV-related stigma. And also 390s are the 90%. That means by 2020, 90% of the persons know that they know their HIV status, and 90% will receive treatment, and 90% they're virally suppressed by taking ART treatment. Okay, so these are the very important points. Okay.
Ma'am, sorry to interrupt, but there is a problem with slide sharing. Can we share the slides instead, ma'am?
Yes, okay, you can do.
Okay, so ma'am, can you stop slide sharing? Okay. Ma'am, please stop slide sharing.
Okay. Okay. Gauri, it's right now. Gauri.
Yes, ma'am, we'll be sharing it now.
Okay. Gauri, I reached up to the target. Okay. Yeah. Okay. Gauri, it's enough. Okay, Gauri. Shall I start?
Yes, ma'am.
Okay. So this is the HIV burden in Kerala as of 31st March 2020. So this is the statistics, this much testing we have done, and the positive cases is about 35,934. So this is the statistic that is available up to 31st of March 2020. Okay, so the next slide. Okay, so this is the HIV testing trend from 2012 to 19. Okay, that is first is the general client population, and second one, that is red line, you can see the pregnant women. So this is only to show that the testing pattern, they are increasing. Okay, so by 2019, our testing reached up to this much number, and also for the pregnant women, their testing also increasing. Okay, so just to show that, I put the slide. Next slide, please. Okay. So next is the services of KESAC, that is Kerala AIDS Control Organization. So this is the counseling and testing service. Okay, so this is the HCTC, that is what is HCTC? So there is a confusion regarding this HCTC. Actually, this ICTC, okay, this ICTC means Integrated Counseling and Testing Center. So previously it was known by VCTC, that is Voluntary Counseling and Testing Center. Why? Because we are voluntarily, we can voluntarily test our HIV status. Okay. So now it is changed to ICTC, means Integrated Counseling and Testing Center, because it is integrated with so many other departments, and now it is known as not known as. We are planning to change this HCTC, that means HIV test counseling and testing center. Why? Because by integrated counseling testing center, there's a confusion that all type of counseling is being done there. So to change that, we are converting that to HIV testing counseling and testing center. There is a and it's not yet changed. And the function of this ICTC is the early detection of HIV and to provide information regarding the transmission, all type of awareness we'll give to the clients. Then link the ICTC to ART centers and other centers. Okay, that is the main function of ICTC. First to detect the HIV, then to give counseling, and to reach the people to ART centers. Okay, that is the main function of ICTC. Next slide. Okay, so the Integrated Counseling and Testing Center. So this, I think, in almost in all government medical colleges, ICTC functioning. So in our college, I am very proud to say that our ICTC was selected as one of the best ICTCs in Kerala for the past 2 or 3 times, and also we got NABL accreditation for the 2nd time. This year also we got the NABL accreditation. So this is an ICTC. We are now integrated with so many other centers like TD Center and TCP. Then we are integrated with STD clinics and so many centers. So it is known by the name of Integrated Testing and Counseling and Testing Center. So a person coming to ICTC, so what are the things that we should do? One, the main thing is the 3 C's are there. One is the consent. We should get the consent of the patient. Next is the counseling, and third is the confidentiality. Okay, so these 3 are very important regarding the testing of HIV. So a person coming to for testing the HIV, first we will take a consent from the patient. That's very important. Then after that, there are 2 counselors in ICTC. One male counselors and female counselors. So they will give the counseling. That is a pre-test counseling. That means to give the counseling before the test. That is to extract the risk factors associated with that. They will ask a lot of questions and they will extract the risk factors associated with that patient. And after that, they will do the testing. Okay. So whether that patient is positive or negative, after that test, we will give a post-test counseling. That means they will give counseling regarding how this HIV is transmitted, how to prevent HIV, and if it is a positive patient. Previously, if it is positive also, we should get the consent of the patient to reveal the HIV status with the spouse also. But now it is changed. We can reveal that the positivity to the spouse and then the relatives. So that may change today. Okay. So after this post-test counseling, what the counselors, what they will do is that they will take the patient to the ARTs, antiretroviral treatment centers, and they will register that patient in the ART centers, and they can start the treatment, okay, from the ART centers. Previously, they will start the ART only after testing the CD4 cell count. But now, regardless of the CD4 count, we will start the ART treatment as soon as the patient is positive. Okay, so they will start the first line of treatment, and the treatment is all free of cost. Okay, so the government is giving free treatment to the patient. And after this treatment, and they will give a kit also. That's a very important thing. That kit contains so many, that is the food items, that is the nutritious food items in this kit. And the patient will get pension also, 600 rupees per month. They will get the pension also. So all type of this helping hand from the NACO and also from the side. Okay, so these are the things that is done in the ICTC. And also I told you, this ICTC, that the 3 C's is very important. Okay, that consent, then counseling, and the counseling part is so very, very important, because so many people they won't reveal the correct how they acquired infection. So by this counseling itself, we'll get the what the risk factors. And after this, what is this test, the post counseling, the patient therapy, and we'll start the treatment. Okay, so the next slide. This is the roles and responsibility. Not so much. Next slide, please. Next slide. This slide I prepared for the class for my nursing students and counselors in our department today. So I didn't change the pattern. Okay, next slide. Next slide, Gauri. Okay. I told the confidentiality and the shared confidentiality. Okay, next slide. Okay, next slide. I told I'll be presenting only the important points. Next slide. Okay. Next slide. Okay. Okay. So now the test that is being done in ICTC. So in the ICTC, we are doing the 3 tests. Okay. You know that the lab diagnosis of HIV, there are specific tests for HIV and also non-specific tests for HIV. So the specific test we are doing, that is the rapid test is there, then there's the screening test. The specific test comes the screening test, then comes the supplemental test and also the confirmatory test. So in the screening test, we are detecting the antibody. Okay. So in the screening test, we'll do the ELISA and also the rapid test or the symbol test. So the ELISA, it will take about 2 to 3 hours. The rapid test, it will take less than 30 minutes. So in the ICTC, we are doing the rapid test. And next is the supplemental test. So if any patient is positive, we'll do the supplemental, not in ICTC. The general pattern is that we'll do the supplemental test. That is, here also we are detecting the antibodies. So the supplemental tests are the Western blot test. You'll be very familiar with the Western blot test. Then there is immunofluorescence assay test is there. And other tests like the radio immunoinvestigation. So these are the tests, supplementary tests. And finally, the confirmatory test. The confirmatory test is the antigen detection. That is, the P24 antigen, that is the antigen test. Then we have got the viral culture. It's not being done today because it's very difficult to isolate the virus. Then we have got the HIV RNA detection. That is the best confirmatory method. That is the HIV RNA detection test. Okay. And finally, the HIV DNA detection, that is for the diagnosis of pediatric HIV. For the diagnosis of pediatric HIV, we are doing the HIV DNA detection test. So these are the tests which comes under the confirmatory test. And some of the non-specific tests, they are the detection of CD4 cell count. Then there will be hypergamma-globulin, all this gamma-globulin based. Then there will be altered CD4 and CD8 cell count. Okay, so these are the laboratory diagnosis, the specific test and the non-specific test. So in our ICTC, we are doing the rapid test. There are 3 rapid tests. Okay, that is, we'll do the first test. Okay, when a patient comes after getting the consent and after the pre-counseling, we will do the first test. So if it is negative, we will report it as negative. Okay, if it is positive, we have to do the second and the third test. Okay, if the second test is positive and the third test is negative, we will give we'll report it as that is undeterminate result. Okay. And vice versa. That means if the second test is negative and the third test is positive, also indeterminate. So what we will do is that we will ask the patient to come after 3 weeks. Okay. Then after 3 weeks, again we will repeat these 3 tests: first test, second test, and third test. So, and if this result is also indeterminate result, what we will do is that we will give this sample to the SRL. What is SRL? That is the state reference laboratory. Okay. From the ICTC, we will refer this patient or we will refer this test to the SRL, State Reference Laboratory. In our ICTC, this SRL is functioning in our ICTC, okay, Calicut Medical College. So what this SRL people do is that they will do this test, all the 3 tests, okay. And whether the result is positive or negative, whatever the result is, they will send the sample to the National Reference Laboratory, that is CMC Vellore. So the National Reference Laboratory for the HIV testing is CMC Vellore. Okay, first ICTC, if it is an indeterminate result, we will refer to the SRL State Reference Laboratory. Whatever may be the result, they will refer to the National Reference Center. Okay, so this is the pattern that we are doing here. Okay. So the very disadvantage of doing the rapid test is we are detecting the antibody. So what is the disadvantage is that the antibody, the window period is there for HIV. So the antibody won't be appearing in the blood during this window period. So when we do this antibody test, what will happen is that it will become negative. Okay, so that is the main disadvantage of this non-specific or this rapid test. So if there is any high risk related to this patient, that means we will ask the patient to come after 3 months and to repeat this same test. Okay, so that is a test that is done in our ICTC. Okay, next slide. Okay, that is the ICTC, that is some program initiatives are there. That is, one is the to prevent the HIV transmission from mother to child. That is very important, that is PPTCT, to prevent the transmission of this HIV. Then for the early infant diagnosis, and also this, you know that HIV patients, they are more prone to develop some opportunistic infection. And the very common opportunistic infection is that is tuberculosis, and that too multidrug resistant tuberculosis. So the main program initiative is to detect the to prevent the transmission of HIV from mother to child and early infant diagnosis, and also to diagnosis tuberculosis in HIV patients. Okay, next slide. Okay, no, next slide. Okay. So these are the these packages. Okay, Gauri, you can change next slide. This is 𝗶𝗴្𝗍. Okay. Next. So this is very important. That is the show me that slide. Yes, slide. Previous slide. Previous. Previous. Yeah, this one. The goal of ART, that is antiretroviral therapy. That is the goal is to reduce virological reduction of HIV, then immunological reduction, therapeutic, and epidemiological. Virological means to reduce the viral load. Okay. Then immunological means to immune reconstitution. Okay. That is to use CD4 count. Next is the therapeutic. That means to prevent the drug resistant and HIV, and epidemiological to release the HIV transmission. These are the goals of IRT. Okay, that's important. Next slide. Gauri, next slide. Okay. So, okay. Okay. Some told you. Okay. So these are some of the diagrams. 4 groups, high risk group. That is transgender. These are the bridge population. That is the chuckers, because the story drivers and all. Okay, Gauri, my slide is, this is the HIV telecounseling phone number. This is, and the ICTC that is started in India in 1997. Okay, Gauri. Okay. I think you will be having this slide with you can share this slide to the students. Total ICTC in Kerala is 154. Okay, Gauri, that finishes my slide show.
Yes, ma'am.
Gauri. Okay, that's all about our ICTC and also the testing and the laboratory diagnosis in brief. I said. Okay. Okay, Gauri.
Thank you, ma'am. Surely your talk has helped us understand the various aspects of diagnosis, transmission, and also the treatment modalities of AIDS and the working of ICTC. Next, I cordially extend my welcome to Dr. 𝗓𝗏𝗏. He has completed his MBBS from Government Medical College, Trivandrum. He did his DPM from Government Medical College Trivandrum and DNB from the National Board, Delhi. A practicing psychiatrist at National Medical Health Center, Trivandrum. His area of special interest is cognitive behavior therapy for anxiety disorders. I invite you, sir, to enlighten us with your words.
Okay. Thank you. I think I can share my slides, right?
Yes, sir.
The option open? Yeah.
Yes.
Okay. Okay. I think all of you can see this.
Yes, sir.
Okay. So I'll be covering how you actually have to do the counseling, or like what will be the experience of counseling a patient who is dealing with HIV. Not that he is positive with HIV, not that he is on some extreme end of the HIV infection. It's just that he is dealing with something called HIV infection. So the counseling for HIV will be a bit different from any other illness. Why? Because this is how, I mean, this current slide doesn't relate to HIV as such, but it's about all the human beings. They think they have a process of thinking, which is always dealing with things about self, things about the world, and things about the future. So this is about these three things people always keep on thinking about. That is how people are actually dealing with me, how others are to me. Now about the world, how the world is like. Is the world a good one or a bad one? Is the world changing? How the world will deal with me? And now he will be thinking the same way about his future also. Will it be good? Will I be able to do this? Will I be able to do that? So these three areas of thinking are always there in anybody's, anybody's mind, which is definitely a function of brain. So, and regarding the second one, that is morals, attitudes, and prejudices. These are something everybody developed since the time of birth by interacting with the society. Okay, so they develop certain morals, certain principles, certain attitudes and prejudices. That is certain rules and law based on which they actually deal with the So you are actually a changed person, or you think you are actually a changed person after your infection. So it's a chronic illness, and once the virus infects you, right now, there is no way the virus is going to leave you. It will be there with you till you actually live. So it's a chronic condition. Now, just because of that, it is going to change your thinking pattern about self, about the world, about the future. People may think that I'm a changed man and I'm a bad person, or maybe like I'm not going to be able to adjust with the world after this infection. Second, they may be thinking like the world is a bad place. They may actually deal with me in a very bad way. They may not accept me after this, and those kind of problems. And now about the future, some of them may think like I don't have any future. Some of them may be thinking like my future is going to be very different from what I was actually expecting. So all sorts of changes will happen in the way he actually thinks about the self, about the world, and about the future just after being infected by HIV. Now, what about the morals, prejudices, and attitudes? If a person was holding very idealistic and very, like a criticizing kind of morals, prejudices, and attitudes, is going to be hit very hard once he gets infected with HIV, because there is so much of things about the sexual relationships, about the modes of transmission, how you can get infected. Just like when we think about HIV, we suddenly may think about all these truck drivers, about transgender people, about homosexual men. These are actually your prejudices, your stereotypes, your attitudes, and everything that is actually there with you since you were born and interacting with the society. So this all will start interacting with your life. And now, the infection of HIV may get you socially isolated if you're not able to deal with it. So with all this, the HIV is going to change a person's life right from the moment he knows that he is infected. So there is a whole lot of things that you have to do in his psychiatric condition or psychological condition, whatever way you want to call it. So what we actually do in the minimum is a person should be able to give a psychological first aid to that person. That is, he has to look at him, identify whether he is going through some psychiatric condition, whether he is having some distress, whether he is having some difficulty, very serious difficulty in dealing with it. Now, after that, he has to listen to that person, allow him to ventilate and ask him about all the things that he is planning to do or the way he is going to deal with it. And once both of these things are done, he should be given the connection to the best or the ideal services that is available. Sometimes the best services may not be available in his locality. So we should at least make sure that the person reaches the ideal place, which is the nearest one. Okay. So this is the minimum that you should do once a person is identified with HIV and he came to you. Now, what about the HIV counseling? There are so many types of HIV counseling. Don't think like this. It's just like any counseling. There's a pre-test counseling and a post-test counseling. The atmosphere will be entirely different and the person will be entirely different. The way he is going to be receptive to you will also be different. And there is something called follow-up counseling. Sometimes it may not be done in the frequency that is required, but still follow-up counseling is very, very, very necessary in a person who is rated to be positive. Now, who does it? The question is, who cannot do it? There is nobody who cannot do, there is no person who can't do HIV counseling, but with sufficient training. Because if there is no sufficient training, I told you the morals, attitudes, prejudices, it's there with every one of us. None of us are actually, free from all these kind of negative influences that we actually gather while we live in the world. So when you counsel a person with HIV, your personality and your way of seeing the world is going to influence the way you communicate to that person. So a person who is doing the HIV counseling need to have very serious one-to-one experience with HIV counseling. Otherwise, they should not do HIV counseling. Okay, so it needs trained people, but whoever it is, if it is trained, good. Doctors are good, nurses are good, psychologists are good, social workers are good, counselors are good, teachers are good, trained health workers, health volunteers, all are good if they are trained. Now, the question is doctors. Okay, you are a students association who are studying MBBS. Okay, are you capable of doing HIV counseling? Right now, I will say, maybe on an intellectual level, like you can tell the person what HIV is, what AIDS is, what is the window period, what you have to do, where your treatment will be available, where you can go, how your partner can get the help. All those things you can tell on an intellectual term. But on the inside of your mind, you yourself will be having difficulties in, like convincing the other person because you haven't gone through any of it, because you were never having the need to face such a condition. So you understand, helping a person on the intellectual level is like just giving the data that what he has to do and what he doesn't do. But it is not that. You have to approach the person on an emotional level. And so you have to tell the person or help the person how to do these things that you're actually giving information about. So it's entirely different. So a person who is giving counseling should at least have an experience in working with these patients. Otherwise, you cannot actually do a good HIV counseling. Okay, so everybody who is into it will definitely be given this sort of a experience and training. Now, where it is done, where it cannot be done, any place where a sufficient confidentiality can be ensured can be given this HIV counseling. But if confidentiality cannot be ensured, if a proper consent, examination, those kind of things cannot be done, no, you shouldn't try to do an HIV counseling. You can maybe do a psychological first aid, you cannot do an HIV counseling. Confidentiality is the most important thing when you are doing HIV counseling. Now, how to do the counseling? In places where you are going to deal with high-risk people, like let's say a place where the people who are in the sex work field actually come for medical help, okay, or maybe a place where transgenders or the people belonging to the transgender community is coming for their medical help. In such places, you can actually do these initial counselings or initial information giving in a group format. And now you may think like, okay, we are not exposed to that. But imagine the ICTC counseling centers or these, what you call, there is a name for that, places where pregnant mothers are given HIV test as well as the counseling. many places they actually try group format or group counseling format for that population, because you don't expect many of them to be HIV positive, but there is a chance. So you can actually disseminate the information in a group format. But when you are asking them to do the test, the consent taking should be on a one-to-one basis. You shouldn't do a group format of counseling and then give them all the consent form and then send one by one to this testing center. No, it's not like that. The information can be given on a group format, but the consent taking again should be on an individual format, because most of them may be having one or other doubt about that. And if such a case is there, that person should be given individual counseling. But if a person is coming to you and is asking for a HIV testing, that person should be given a individual counseling first, and then the testing should be done. Or any person who is becoming positive should be given only individual counseling at first. After that, you may have to incorporate their family members, their partners, or all those kind of people with consent. Without consent, you cannot involve anybody else into their counseling. Okay, so there is individual counseling, there is one-to-one counseling, and there is group counseling also. Now, what is the 5 C's related to, which is a common kind of a term which is used with HIV counseling or maybe with many counseling? There is consent, which is very, 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 very essential. You cannot do the testing without the consent. A doctor cannot simply ask the patient to go and do the counseling. The patient will go there with the doctor's request, but at that place, the testing person will actually ask you, did you actually consent for the test? If the patient says, no, I did not give the consent, the test will not be done. A doctor cannot force a patient to undergo the testing without his consent. Okay. There are situations where the legal issues are there and the person may be asked to do the HIV testing. So the legal orders, like the court's order, will always supersede anybody else's decision. So consent will not work over there. Let's say child abuse, the perpetrator is brought for testing. He may not be giving the consent, but still the test may be done. There are provisions for that. But most of the places with some counseling, everyone will agree for the testing, but the counseling is important. Now, confidentiality. Without maintaining the confidentiality, you cannot do HIV testing. If you breach the confidentiality, you will be penalized for that. Now, counseling. Like any counseling, you have to follow the basic rules of counseling, and there are certain specialized counselings that are used in HIV, which I will be coming to. Now, the correct results. Because patients will be having certain beliefs like, okay, my screening test is negative, okay, done. I'm not having an HIV, I'm free. And whatever things that I did till now, which put me at risk of HIV, will not put me at risk for HIV. He may think like that. Okay, he may take the results and then generalize. So imagine a sex worker coming and doing the test every 6 months and her test is negative. She may be thinking like she is, like kind of resistant to all this, and all these things like HIV, AIDS and all is actually a hoax. Okay, so a proper counseling will actually help the person to interpret the results properly. And the results that you give should be correct. Like you should say, it's a screening test. You should say like, no, you are still in the window period. You may have to do it again, or you may have to wait and then do so many things. You have to help the patient to interpret the results properly. Now, what about the connection? Connection means once that result is there, you should then link the person to the proper place from where they can receive the further informations or further interventions. Now, the basic counseling skills that is required. For any counseling, you need listening skills, but what actually is needed is the active listening skills. Like you should be able to establish a rapport while listening to that person itself, and many sort of communications actually happen in the non-verbal manner. Okay? So you should be able to check your non-verbal ways of communication as well as the client's non-verbal ways of communication. If this is not kept in mind, we may actually take the patient's words literally and then think like, okay, he is meaning like that, but he may not be meaning that on an emotional level. Like he will say, yeah, I understand. Then you may think like, okay, he understood everything. Now give me the consent and go. The person may be saying like, okay, this is hopeless. I'm not going to understand anything. This is what actually the patient meant. So you have to keep in mind the non-verbal methods of communication, his ways of sitting, his way of dealing with the results, his way of handling the papers, his way of sitting in the chair. All these things are important. Your ways of dealing with that is also important. Now, good emotional control. Why this is needed? Because once a person gets detected with HIV, there is no guarantee that the person will react to that in a accepted kind of a toned down manner. No, they may shout, they may get angry, they may cry, they may throw the result away, they may bang the door, so many things they may do, but you cannot lose your cool. Now, what about patience? You need that. Now, what about non-judgmental attitude? Like I told you, like a person who is a female sex worker or a male sex worker, they come, they do the test, they became positive, and suddenly you get a feeling like, I told you so. That kind of a attitude in your face will not be good. You may actually give them the result and then sit them and looking into their eyes like, I told you so. No, that is very bad. That cannot be accepted. So you need to have a non-judgmental attitude. And what about the last one? This is very important because motivational counseling skills. This is not like any sort of motivational test like you are telling them, see, nowadays there are lots of treatment for HIV, there is ART, there is free medicine, there is free food, there is pension, there are so many things that are given to you. Okay, so much of information, but the patient will not feel motivated. Okay, there are certain ways in which a motivational interviewing is to be done, and motivational interviewing itself is a separate branch of a psychological intervention. And if it would be better if anybody who is doing the HIV counseling learns that sort of counseling also, motivational interviewing. Now, why you need to do counseling? Why can't you just ask everyone to test because it's your let's say duty to the country? Okay, you cannot say like that. The reason why you are actually doing the counseling is you need to detect HIV as early as possible and correctly also, because the number of cases you actually detect means the number of further infections actually come down. Now, effective prevention strategies at the earliest. Now, the previous slides it was said like premarital sex, adolescent sex. Nowadays, children are actually having the sexual practices much early. Okay, previously in colleges and all, it was not very bad there, and it was actually an opportunity for a rare few, but nowadays it's quite common. So I'm not generalizing, but it's definitely commoner than the previous times. So effective preventive strategies should be implemented and should be taught, should be practiced at the earliest. That is very important. Now, what about reducing further infections? Now, a person detected with HIV, can he have sex again? Can he have contact with his partner again? Or should he live a very hermetic kind of life, go to a mountain top and live isolated? No, it's not going to be like that. He's always going to interact with the society further. So in that case, he shouldn't be a source of a further infection. He should be educated, and it should be ensured that he actually practices whatever that he is taught. Okay, so not on the intellectual level, but on the emotional level also, he should change. A behavioral change should actually happen from your counseling. Okay, a behavioral change for the whole lifetime remaining in the patient's or the person's life should actually happen. That should be the impact of your counseling. Now, avoiding the bad consequences of a positive test. People can react with even suicide once they are detected with it. So the way they give information to the patient that they are positive is actually in a very soft and a careful manner. They don't just send the result on the mail to that person so that the person can open it, or maybe the person's mother, daughter, or somebody may open it and see. No, it's not done like that. It's given in a sealed envelope. It's given directly from the counselor to the patient, or maybe the person in charge of the center will be giving it to them. So there is a very guideline-driven method by which you have to give the information to the patient. And what is called psychosocial stability. Now, once the person is detected to be HIV positive, he may lose the stability or the psychological stability, as well as so many things change in his life. So you have to be with him till he achieves the stability in his life again. So what are the expected psychological issues? This should be kept in mind, and a lot more should be kept in mind, because any sort of reaction can actually happen after this getting an HIV positive result. Denial, some people may actually deny that it's all a hoax, you are not giving me the proper test, I'm going to test somewhere else also. Some people may deny it and then go and have sexual practices further. They may infect many more people again. Some may just deny it and then go and commit suicide. So many things can happen. Depression can develop from that. Depressive disorders may develop from that. Both these things are different. Depression means sadness. A serious sadness may develop, or maybe a person can go into depressive disorder. A real serious mental illness may develop. Anger can happen from that. Anxiety may happen from that. Sleeplessness may start and it may never end after that. Suicidal ideas will develop. Ideas may develop, then they may plan for it, and then they may commit suicide. So it's up to the person who is sitting for the counseling or the person who is giving information to make sure that the person is ready to receive the diagnosis. Okay, so it's a lot of work. Now, what about the worried well? Worried well means people who actually are doubtful that they have HIV, so they want to test. They may have all sorts of symptoms and they may think like this is HIV and they may go and do it. So why should a person develop this kind of a doubt? One reason is there may be people at risk. Okay, they are worried because they are at risk. So these people, when they come for the counseling, the pre-test counseling is very, very, very important. You should tell them, you should keep on motivating them to change their lifestyle. You should keep on motivating them, and finally they decide that, okay, enough is enough. I'm not going to be at risk again. I'm going to stop all this. Okay, after that, he may not come for testing because he is free from the risk. Now, what about people who are not at risk but just having the doubt they are having AIDS or they are having HIV? These people need a little bit of information, but the problem is the more information you give, the more doubts they actually start to have, and they keep on repeating that testing. So at this point, you should actually refer the patient to a proper psychiatrist or a psychologist, anybody who is expert in dealing with that, because it needs expert intervention in cases, because this may be a serious anxiety disorder, it may be a serious delusional disorder, it may be a part of another psychiatric disorder. Okay, so you have to take care of all these worried well people. It's not that you shouldn't test them, you should test them, but if they repeat the test and if they're repeating the test beyond a serious point of time, you should actually evaluate them psychiatrically. Now, what about this pre-test counseling? What is actually pre-test counseling? Why you are giving the pre-test counseling? Simply to initiate a behavior change in that person. Not all people who are undergoing pre-test counseling will be positive. Then why you are wasting the time? You are not wasting the time. You are instilling a behavioral change. That is, a person at risk will actually become free of risk. So it's up to your counseling to change the person's risk-taking behaviors into a very cautious behavior, which involves safe sexual practices, safe injectable drug use behaviors, safe, all these truck drivers should be educated how to spend their time when they are actually very bored, sitting in the in their what you call the lorries and all. So you have to teach them how to remove the risk in their life. So detect the high-risk behaviors and reduce it. Partner counseling. Okay, you have to think about that also during the pre-test counseling. It's not just that person, but you cannot counsel the partner without the patient's consent. So with their consent, you should actually try to do the partner counseling. Safe sexual practices. You teach the people all sorts of safe sexual practices. So regarding the male to male sexual active people, you have to teach them how to do that in a safe process. So now you understand, you have to keep all your attitudes, prejudices, morals, ideals, and all sorts of things back at your home, and come sit with a non-judgmental attitude, look at your patient, listen to them, and then give them the information and try to bring in them the real behavioral change. So now you counsel a male to male sexual partner. They are telling like, no, we cannot stop doing that. We are going to do it definitely because I'm in love with that person. So now what can you do? You can teach them the safe way to do that. Okay, using the condoms, frequencing it, reducing the number of times you actually do that. There are other healthy ways of doing sexual practices without doing the anal sex. The anal sex actually increases the risk to such high levels. Okay, so all sorts of things you have to teach them. Not teach them, you have to give the information, then they have to change. Partner counseling, safe sexual practices, high-risk individuals. Look at these high-risk individuals and go to the last part, what I have written. The initial things say multiple sexual partners, injectable drug users, man-to-man sex partners, sex workers, and now comes adolescents. Okay, adolescents are at risk. Now, why would I involve adolescent people into such a dangerous group of people? And I have written like health workers and prison population and personality disorders. What wrong are they actually doing? See, the problem is that they have to be very careful of their work atmosphere. Adolescents have to be very careful about the habits they're actually starting. Many habits. Nowadays, people actually go for trekking. They go for like 2-3 days of trekking. Maybe they go with strangers, like two friends may go with the other two friends. They may not be knowing each other. They might be meeting together in WhatsApp groups or Telegram groups and all, and they're going. So they have to be careful that they don't follow any dangerous, risky behaviors, maybe snuffing all those drugs, maybe taking an injectable drug and all those things. So adolescents should be given information about all these things. Otherwise, a proper behavioral change will not happen till they actually go through a lot of danger. Okay, so pre-test counseling is not just sitting with a person who is coming to you and giving them all sorts of information about AIDS and all. No, it is about behavioral change. Now, the last sentence is what I was talking all this time. Knowledge doesn't bring action. Okay, well, all our college-going students, all our doctors, and maybe like many people in the society, they all have such deep knowledge about HIV and maybe about AIDS. They may have gone through all the videos in the YouTube and all those things, but they will not be practicing anything at all. So why that is happening? So you have to understand, knowledge just gives only an intellectual kind of a influence on the person. What you need is an emotional influence on that person. The person should change their behavior right after getting this education. Okay, so counseling must ensure this emotional level of behavioral change. Now, that is called the stages of change. Stages of change actually is a theory put forward by two people. It's actually say that a person who is following a particular behavior and you want to want that person to change the behavior, you have to give them something called motivational interviewing or motivational counseling or a motivational communication. And with that communication, the person will go from these different stages. That is pre-contemplation, where the patient was or the person was not at all thinking about stopping their risky sexual practices. From that stage, he may start thinking, okay, so it is like this and it is like this. Okay, so maybe I should try some of the safe sexual practices so that my risk actually comes down. Good. That is the contemplation phase. Now, what is the determination phase? Okay, I'm 100% sure that I have to change and I'm going to change. That is the determination phase. And now they will actually try the action phase. That is, try to use condoms, or maybe in a female sex worker, try to say no to the male the customer who actually wants to do the sex without the condom. So trying to say no is actually for her a big behavioral change. So as a pre-counseling, HIV counseling person, you have to bring this change in that high-risk person. If that is coming, she will not be at risk for HIV anymore. Now, what about maintenance? That is going with this particular change of behavior. And what about relapse? Any person who changed for good is at a risk of going back to the old ways. So this stages of change actually is there in any one of us, every one of us. It's not just about HIV. It's more about all these risky behaviors, but still it is about any behavior. So just like this, a counselor has to keep in mind, our people are actually going through this, and we have to keep on motivating them to move from one stage of change to the next stage of change, and like that to the final behavioral change. Now, is there a specialized psychotherapy technique by which you can deal with some of the things related to HIV? There are so many specialized psychotherapy techniques. One such technique is cognitive behavior therapy. In cognitive behavior therapy, what we actually do is you actually assess the kind of thoughts that the patient or the person is actually going through. So some of the thoughts are called automatic thoughts. That is, say a person after getting their HIV is keeping on thinking, my life is finished. My life is finished. What else do I have? My life is finished. It's gone. It's done. It's finished. So a person keeps on thinking like that, and he will develop further negative thoughts, and finally he may go into depression and he may go into a suicide. Okay, so you detect these kinds of negative automatic thoughts and you help the patient to challenge that, to change that. Okay, so this sort of a therapy is called a cognitive therapy. And now what about behavior therapy? See, find the alternative thoughts, that is the good thoughts, identify the errors in his thinking. What about relaxation techniques? The person is going to deal with the stress related to HIV all through his life. Now, we all said many things like going to the ART center, getting the free treatment. Now, going to the ART center is kind of a very severely stressful thing for a person who is newly detected to be HIV positive. Till he gets familiar to that, until he achieves a psychosocial ability, he needs to learn a lot of relaxation techniques so he can deal with this new stress that has come to his life. Now, what about acceptance and living with the diagnosis? So many people actually ask, like, okay, now you have detected me to be HIV positive. How long will I live? Okay, there is no guarantee that the person will live for this and this, because textbooks say like now there is treatment. Many people will not be tolerant to their treatment. They will develop very serious side effects, much worse than the infection. So they may stop the treatment. So no, they shouldn't stop the treatment. They should look for ideal other alternatives. So they have to accept their current diagnostic status, and they have to live with the diagnosis. So they have to learn certain techniques by which they can tolerate the distress. So such techniques are called one of such technique is mindfulness techniques. So they have to learn these kind of specialized interventions. Now, ensuring responsible behavior. How will we ensure responsible behavior? A person is telling, my life is finished, there is nothing in front of me, but when you ask them, you understand that they have 2 children. Okay, and these 2 children are only very young, and their wife is not a very capable lady. So now the aim of the person with the HIV positive can actually become that he has to make his life, he has to make his wife self-efficient. He has to give the children good education, and he has to ensure that he takes care of many of those kind of things before he gets very weak with the HIV infection. Seems very melodramatic, but when you sit with them, their thinking will also be the same, but among so many negative thoughts and all, they will not be able to think clearly. Okay, so a counselor's role is to use proper therapeutic or counseling techniques to help the patient think properly, cut down all the the noise, all the bad noises around, think very clearly, find out the proper intervention that he has to do, and then stay with him till he is able to do that. Now, for all this, there are national guidelines, because HIV and dealing with HIV is not a individual a war or something. It's a national thing. Okay, so the nation, or our nation, that is India, definitely brings out guidelines. The latest is what Madam said, like 2017 and all. So you have to keep in mind what guidelines they are actually coming from. And now there are certain departments like social justice. There are many departments which are actually giving benefits for these people. There are many places where these people will be getting disability benefits. There are many places where they can be given some help in finding employment. All these things are actually coming under the government measures and policies. So a person who is giving counseling should be having an awareness of all this. If he is not able to give the information regarding to the specific area, he should refer to the expert counselor or the expert psychotherapist or to the expert doctor or to the expert medical health volunteer, anyone. So expertness is, first you should decide how expert you are, and if you are not expert enough, refer them to the next place. Thank you. That's all from my side.
Thank you, sir. That was a very informative session on HIV counseling, and I'm sure we all gained valuable information about the process. And now I feel extremely honored to welcome our last speaker of the day, Dr. Ashwath Kumar. He completed his MBBS from Government Medical College, Thrissur, and MD Gynecology from BJ Medical College, Ahmedabad. He completed his FICOG and Diploma in Advanced Laparoscopy in France, and Diploma in Management of Advanced Endometriosis in Austria. He's currently working as the Professor, Department of Gynecology, Jubilee Mission Medical College, Thrissur. I proudly invite you, sir, to talk to us on HIV in pregnancy.
Thank you so much. Gauri, shall I share my screen?
Yes, sir.
Yes. Okay. First of all, I thank. It is clear. My audio is clear. Gauri, my audio is clear.
Yes, sir. Yes, sir. It's clear.
Hello.
Yes.
Yes, it's okay. Anything is there, you just tell me. The audio is not clear or something is there, just tell me. So
Yes,
first of all, I thank the organizers, that is a medical South Indian Medical Association, Students Association, as well as Gauri for inviting me for this talk. Also, my friends and 𝗶𝗴្𝗍𝗰𝗃 also for suggesting my name to Gauri. So here you heard excellent, well-covered talks by two people. So things have become very easy. So I will be going around. Gauri wanted me to tell some details about the general HIV also in the clinical part. I will go through it so that you will know the basics of basics in total, because there is no other talk, but the madam had already covered very well. Okay. Without wasting time, now the next 15-20 minutes, we will be going through what is HIV in pregnancy. So this is a report that is in that the prevalence is in the society is 0.26%. Every year there is about 86,000 new cases, and people living with HIV is almost 21.17 lakhs. And HIV infected women, you can see every year is now the number of HIV infected women in total, that is about 8.46 lakhs, and number of HIV positive pregnancies is 43,000. And you can even see the children level less than 15 years, there is also 10,500 people are there. So let us see the transmission without, if you don't take ART, antiretroviral treatment, what is transmission? So if you take pregnancy as such, if you have not taken ART, then it will be 5 to 10% transmission. Labor and delivery is still high. It is 10 to 15%. When it comes to breastfeeding, Without breastfeeding, it is 15 to 25%. With breastfeeding, that you mean that it will be transmitted through the breast milk, it is 20 to 30% and 30 to 40% up to 2 years. But this is important. They will ask you in exams, if you have given ART, parent to child transmission can be reduced by what percentage? It is even a postgraduate entrance question. You will be also knowing all these questions are asked actually. Parent to child labor delivery, all these things are important postgraduate entrance questions also. So don't think that these values are just put like that. And you all know the heterosexual behavior, that is what been highlighted by the previous two speakers. And you can see the second highest comes parent to child transmission is almost 5%, almost 5%. So this is how the important is parent to child transmission. And another very important thing is the blood and blood products and intravenous. Okay. So coming to the, what are the factors influencing this parent to child transmission? Divided into maternal factors and infant factors. Like any condition in pregnancy, we divide, say that this is the maternal factors and this is the, so timing of infection. Early the infection, chance more. So it can be early, late, or during labor. Type of disease, if it is a symptomatic disease and or asymptomatic, symptomatic means the chance is more. Then you have to see the viral load, CD4 count, immune status of the patient. So then duration of ART that is being taken. If the ART is taken throughout the pregnancy, many times HIV testing is not done in the early pregnancy periphery. When it comes to a tertiary hospital towards delivery with some complication, when you check HIV, it becomes positive, and then only you are starting ART. So the ART is not started from the beginning itself, and it is not a good sign. Then genital tract infections are associated with more chance of HIV infection. Now, what are the infant problems or the fetal problems which can lead to preterm baby, more chance to get an HIV infection? When it is a low birth weight baby, the immune status is low. So if they have an immature GIT and if they have mouth sores, there is high chance for transmission. Then genetic susceptibility, that is, this you can learn, CCR5 deletion. This is for a, and if it is a mixed feeding, we will come to it after some time. What do you mean by mixed feeding? Why it has more chance of HIV infection? Now coming to effect of opposite, effect of HIV on pregnancy and pregnancy on HIV. So any medical disorder, you tell like that. Anything you learn. See, if you learn an infection like malaria, you say malaria on pregnancy, pregnancy on malaria, like that. Tuberculosis on pregnancy, pregnancy on tuberculosis, like that. Effect of HIV infection on pregnancy. So there is increased chance from, if you take from the first trimester itself, abortion, you learn only one, increased chance of abortion. IUGR, 2 times chance is there. Preterm labor, baby can die inside or during that process of delivery. Birth weight, an increased risk of anemia and low birth weight baby. So all these things are abortion, IUGR, preterm labor, stillbirth, anemia, maternal anemia, and low birth weight babies. Okay. Then what I told you, the opposite, effect of pregnancy on HIV. As such, you know, immunocompromised condition, pregnancy as such. So the HIV infection is slightly accelerated and hastens development of AIDS. If he has an HIV patient not treated, it will lead the process to AIDS syndrome. It will be very fast. Now coming to plasma H1 RNA, unaffected in pregnancy but increases in the postpartum period. Okay. Due to hemodilutant, the CD4 count can come down. Okay, that you should remember. So that's a question which is asked. See what happened normally to a CD4 count in pregnancy, it will come down. After delivery, CD4 count increases. Okay. And unprotected intercourse and viral load increases the viral load. So about counseling, I don't have to, sir, as beautifully. I also enjoyed the talk by Dr. Kiran. It was so good actually. So you explained the counseling part so well. So I don't have, but you should know certain small points. What do you mean by a preconceptual counseling? That is what he told clearly. Prevent and treat all sexually transmitted infections. You have to counsel the patient about the number of pregnancies and outcome if you have a patient with HIV. Length of stay with the partner and HIV status of the partner and condom use should be specified. Avoid smoking and substance abuse and encourage folic acid intake. So what are the things you will do in a preconceptual counseling? These are the things you will tell them that to prevent and treat STS, sexually transmitted diseases. You should, number of pregnancies should be restricted, and the outcome should be explained to them if they are HIV. Stay long, how long, frequency of intercourse, partner use of contraceptive, condoms, especially condom. Condom is the only protective, direct protection of a contraceptive. Avoid smoking, substance abuse, and all alcoholism, smoking, and all can decrease the immunity, increase the effect, and encourage them to take folic acid. There are two types of, this is one thing which is asked in PG entrance exam. Opt out. This is what is used. Opt out means what we are doing. Patient comes to us, a pregnant lady, we tell them to do the HIV test. This is what's called opt out. Opt in means goes and tests is what is called the opt in. So two types are there. So Peter counting, you have to inform consent testing is obtained. In case refusal, client is again counseled again, and the test report is always kept confidential. All these things are the post-test counseling, which was explained very well. You have to tell about the disease study. If you get therapy, follow-up, behavior modifications, safe sex practices, contraception, antenatal care, mode of delivery and breastfeeding, whatever is there, you have to explain everything to the patient in detail. This was all explained by Madam. Each things as it has. So if you see, say you have ICTs, you are ART centers, and you have Center of Excellence in HIV care and pediatric care of excellent medical setup. District hospital comes, you have ICTC and ART center, you have a blood bank, there you can have sub-district. So all facilities government has given, you can see such a, it is NACO has provided, the government has provided such a nicely so that we can prevent, we take care, we can eliminate HIV in the next 50 years. There will not be an HIV. The students like you will be studying like what we say smallpox. They will be hope that they will be studying something like, oh, there was a disease called HIV. Coming to, this was what Gauri wanted me to tell few things, disease classification. So whenever a patient comes to you, WHO has told a clear-cut classification. I have made it very simple for you. See, there are 4 stages. Stage 1, you remember one thing, patient is having persistent generalized lymphadenopathy. One thing you remember, otherwise too much thing to remember is very difficult. When it comes to, so it is, if you take general, asymptomatic, mild symptom, advanced symptom, severe symptom, that is what. So 1 or 2 symptoms you have to, common symptoms you have to, and the weight loss. See, in a mild symptom means there is a moderate weight loss of less than 10% weight loss. Okay, that is one point. Patient may be having recurrent upper respiratory tract infection and recurrent oral ulceration. These are all common things. There are so many things, but at least learn at your level 2-3 things, okay, which have. Advanced symptom means patient has a unexplained severe weight loss more than 10%, but less than 10%, more than 10%. Here comes pulmonary tuberculosis, diarrhea. For us, gynec I have marked in red, cervical dysplasia, persistent fever, oral candidiasis, anemia, that is hemoglobin less than 8, neutropenia means less than 500, and thrombocytopenia less than 50,000. So these are some of the common things. So tuberculosis, grade 3 it is. Oral candidiasis, grade 3. Thrombocytopenia, blood, in these stages, and there is a weight loss more than 10%. That's grade 3. Coming to stage 4, that means severe symptoms. That is HIV facing the patient will be something like an emaciated cancer patient. Hemocystis, esophageal oral candidiasis comes in clinical stage 3, while esophageal candidiasis, CMV, Kaposi sarcoma, pulmonary tuberculosis is stage 3, while clinical stage 3, while extrapulmonary is stage 4. Cervical dysplasia was stage 3, cervical cancer. This is according to our gynec. We are more concerned in that. Okay. Now, care and assessment of, coming to care and assessment. So, a patient has come to you. First thing, what will you do? HIV positive patient has, so you are sent to ICTC and the report has come to all ICTC. It is free of cost. Even in Jubilee Mission where I am working, there is an ICTC. So we send to ICTC, the patient HIV testing is free. So the government, you imagine, is providing ICTC centers and even hospitals. So that is a effort that the government is taking. You have to be with them. That is the only thing. So you are the generation. You have to counsel the people properly to go and get it done. So whenever the patient has come, so leave all these things, counseling and HIV they have done, and they have come to you with a test of HIV positive. First thing what you do is that you clinically state the disease. Then the importance of clinical screening for tuberculosis has to be done. Why, I will tell you after some time separately. Then, as I told you, we learned screen and sexually transmitted disease. What we do is that we take a pap smear and VDRL. Then baseline CD4 count, and also advice for CD4 count, not only the RNA viral load also, viral load also we will see. So all this baseline thing we are seeing, hemoglobin, RFT, LFT, warranted clinical signs and symptoms. Lipid profile, RBS, baseline and 6 in 1 year, especially if you are on lopinavir, ritonavir, boosted lopinavir, that I will come to it after some time. So these patients have hyperglycemia, lipodystrophies and all these things. That is the reason why we have to do this lipid profile, and otherwise no need. Okay, otherwise lipid profile doesn't come in the routine. So what will you do? A patient comes, come on, then you ask in an exam, an HIV patient is there, you do a WHO clinical staging, you screen for tuberculosis, you screen for STI. These are for same HIV patient everywhere. CD4 count, RNA viral load, hemoglobin, LFT, RFT has to be done. And if the patient is on ritonavir boosted lopinavir, you remember like that, then you will do lipid profile and RBS baseline. Now coming to antenatal care, okay. See, we have to, certain things we have to see careful. No invasive testing should be there. So CVS is chorionic villus sampling and amniocentesis should be avoided. Iron, calcium, with the vitamin supplementation also. It's all viral diseases, immunity. So nowadays, even in corona, we give a lot of vitamin C. See, if you have been to, you are missing a chance as a MBBS student to be in the hospital. You learn so many things actually if you had been there in the hospital now. I don't know that is why I think the government is forcing you have to send it's an occasion to learn so many things. See, initially I was also reluctant to get posted in a COVID ward or a COVID QT. Now, once I went to the COVID duty, I understood that so many new things I learned and so many things has to be, because in an era, because this is going after 15 years or 20 years, you want to teach the students, your students, okay, or my children, that you will be your students. And you have to know what you have been gone through. At that time, you cannot say that we sat in a house for 1 year and enjoyed. We don't know what was going on around. So all this vitamin supplementations, folic acid intake, high protein diet, monitor weight gain, and almost you have to start the patient on cotrimoxazole prophylaxis if the CD4 count is less than 350. At least you learn that. We will come to it. You learn that there is something called cotrimoxazole. Now the CD count is less than 350. That also I will ask in the exam. Previously it was less than 250. Now it is less than 350. You have to give a cotrimoxazole. So start ART. So the patient, irrespective of the trimester, whenever your HIV positive report is there, you have to start ART. Now, these are things which usually we do. So you have to clinically baseline, whatever we have told, clinical evaluation, adherence, counseling, weight, hemoglobin, RFT, LFT, urine, CD4 count, viral load, blood urea creatinine, RFT. So blood grouping, HbA, other screening for HBV, HCV, VDRL, blood sugar, lipid profile, all these things. See, all that, see, if you can see here, baseline, then 2 weekly, 4 weekly, 8 weekly, 12 weekly, then every 6 months. That is what the pattern. In that, if you only see this, they ask you CD4 count, how frequently you repeat. Once you have done this for count, you will repeat only after 6 months. Okay. So CD4 count is repeated only after 6 months. So that is what there are certain things, and the other screening also you do it for once only. So immediate baseline, you don't do the screening here at all. So this is a nice start. Though you can take a clip by a mobile. If you are viewing, you can take a clip of it. So coming to antiretroviral drugs, this also Gauri wanted me to, otherwise I would have gone fast on it. What is the treatment? Gauri wanted me to run things. For your MBBS, this is called nucleoside reverse transcriptase inhibitors. But these two are nucleoside. and this is nucleotide. So this is a nucleotide in tenofovir, is a nucleotide. T for tide, you remember. Nucleotide inhibitor. So the others are NRTI. So pseudobudine and lamivudine. Nucleoside reverse transcriptase inhibitors are nevirapine and efavirenz. Nevirapine and efavirenz. Protease inhibitors are what I told you, ritonavir, boosted, lopinavir, I told you. So that is the reason why here it causes hyperglycemia, diabetic acidosis, lipodystrophy, and all deranged liver function. That is the reason why you have to do frequently this LFT, lipid profile, and RBS when you are on a ritonavir boosted lopinavir regime. We will regime that is used. So please, children, once more, this is for you to learn NRTI, NNRTI, and protease. Only 3 groups you have learned in pharmacology. NRTI, there are 2 things. NRTI means nucleoside reverse transcriptase inhibitors. You have pseudobudine and lamivudine. Nucleotide, you have tenofovir. NNRTI, non-nucleoside reverse transcriptors, you have nevirapine and efavirenz. Protease inhibitors, you have lopinavir and ritonavir. Okay, this is how we will come to it after details. I will tell you. Now this is the regime. See, all the regime. See, even if it is not the pregnancy regime, it's only one regime now. HIV 1. This is a common HIV. HIV 1. This is the only regime that is available. You have a common T. Everybody today onwards, TLE. You know, okay, everybody should know only one TLE. Today, after my talk, please TLE, you know, tomorrow morning it's more than enough. TLE, what is TLE? TLE is a regime. So it's a tenofovir, lamivudine, efavirenz regime. So it comes under tenofovir 300 milligram, lamivudine 300, and efavirenz 600 milligram. See, it comes as a single tablet. They have to take only one OD. So that is why it is easy to use. This fixed dose regime is easy to use. Advantages of procurement and stock management. So as it is only a single tablet, it does complaints, and it also reduces the drug resistance due to these fixed dose combinations. So this is one. Alternative regimes are there. ACT alternative regimes are there where you have pseudobudine can be combined with the pseudobudine can be combined, and instead of efavirenz, nevirapine can be used. So these are small things can be changed here and there, but basically it is TLE regime. So unless you learn TLE, it is the easiest one. TLE. Okay, this is what is for all HIV patients. See, previously it was different for a pregnant lady and different for the. See, you should understand that when I was a student, see, what the only drug available was pseudobudine. Pseudobudine was given throughout pregnancy, and then when I was a house surgeon, then the only drug available, nevirapine. And the question in the entrance exam at that time was a drug of choice for HIV patient in labor. And we all used to write nevirapine. Now it is not like that. You will not see her. Pseudobudine you are not seeing in the list. So now it is TLE. That is tenofovir, lamivudine, efavirenz. Okay. So you remember that tenofovir, lamivudine 300, and double dose efavirenz is 600 milligram. Now let us see. About simple. I will tell you this slide has everything. See, a patient with HIV comes to you. A pregnant patient comes to you. Sorry, pregnant patient. You have done HIV test and it is negative. So the question is that will you repeat HIV test in pregnancy, thinking that there is a window period of 6 weeks? Don't repeat usually unless patient is from a high risk category. Okay, multiple sex partners are there, or some risk associated other sexually transmitted diseases are there. So then you may repeat after. Otherwise, we don't repeat. So they will ask you. You don't have to do. Now the newly detected patient has come to you. 6 weeks you have done the HIV test and it has come as positive. So that is done in an ICTC. Okay, ICTC center, the blood is collected, and then a patient is sent to an ART center where they will check the CD4 count. Okay, after checking baseline thing, CD4 count, every patient is given TLE regime. Okay, every patient is given TLE regime. Okay, tenofovir, you understood? Okay, lamivudine, tenofovir, lamivudine, efavirenz. So after this baseline investigation, Whenever you started, you have to continue it throughout the labor for a lifelong. Continue this ART for the mother lifelong. After delivery also, this is given to mother. Baby, up to 6 weeks, we give nevirapine. You learn like that now. Okay. Now, if a patient comes, third group of patient is an HIV patient, previously on ART, becoming pregnant. Okay, what will you do? So you have to continue at ART as per guidelines. Nothing else. Although it's the same thing, TLE is what is she taking and continuing TLE. Okay, this is what. Now, previously, see, then I was this 𝗶𝗴𝗯𝗶𝗃 came into market. There was a big hangama telling that 𝗶𝗴𝗯𝗃 causes neural tube defects, and it was not given to pregnant ladies. And it was given to pregnant ladies. Later, 𝗶𝗴𝗯𝗃 has a better efficiency. So later studies found that there is no increased risk of overall birth defects in the infant. So please, so now it is TLE only. Again, that word today, one word, TLE, TLE, TLE. That is what you are going to learn. So that is how it is there. Now let us see. Patient has prior exposure to NNRTA. Okay, prior exposure to NNRTA, I will show you, going back, I will show you what is NNRTA. That means patient had a prior exposure to nevirapine or 𝗶𝗴𝗯𝗃. Okay, imagine. Or she has developed cross-resistant with 𝗶𝗴𝗯𝗃. She was on nevirapine, cross-resistant 𝗶𝗴𝗯𝗃. NNRTA is of no use. Okay, then what will you do? Then you have to, this is style when you change into lopinavir, ritonavir boosted lopinavir regime. Okay, ritonavir boosted lopinavir regime. And also this is the same regime given in HIV-2. If you are asked HIV-2, it's not common. HIV-2, what is the treatment? It is in medicine also, it's the same thing, no change. So this is for you to learn. Okay, so only if the patient has been exposed to an RTA before, developing resistant vitamin will be cross-resistant, then you can an RTA. Then only you go for the ritonavir boosted lopinavir regime. So here the problem is that here this was only one tablet. Here you have one tablet of tenofovir lamivudine, only one tablet. You take any time. But lopinavir, you have to take 2 tablets in the morning and 2 tablets in the evening. Total 5 tablets has to be taken. So you lopinavir, you have to take 2 tablets in the morning, 2 tablets in the evening, and other tenofovir and lamivudine, 1 tablet only you have to take. So this is how it is done. Okay. Now the patient is already receiving ART. It has to be continued lifelong throughout the pregnancy, and so you know that there is no, they will be a TLE regime, and previously what they used to do is that they will be on TLE regime, and pregnancy we used to change it into nevirapine. It is not done nowadays. Don't answer in the exam. It is continued with the with E itself, 𝗶𝗴𝗯𝗃 itself. Will not replace it with nevirapine. Okay. Then I told you what is when will you give 𝗏 prophylaxis in pregnancy? Prophylaxis, the CD count drops below 350. So it will be continued for the pregnancy, delivery, breastfeeding as per national guidelines. It has to be continued. Well, it's a double strength tablet. Previously, in my childhood days, other respiratory infection and all urinary tract infection, we used to use a lot of clomiphene citrate. Like not because I'm going back to infertility. So sorry, it's a 𝗏𝗏 Bactrim DS was the tablet which is very famous. Nowadays we don't give due to sulfur reaction, and the sulfur has to be. When my child was admitted with UTI in Amrita long back, that is about 20 years, 17 years back. At that time he was resistant to all the drugs, and we don't know they was only 3 months old, and they were not knowing what to do, and finally they give 𝗏𝗏 syrup and use it. So with 𝗏𝗏 unnecessarily, many times it is last resort we take it out like that because of the sulfur reaction. Because reaction we don't take it. But in these patients we have to take it. It's an oral drug. It's very easy to give. Good compliance. We have to 1 tablet daily. It's a double strength tablet, DS tablet. It has to be given. So after 6 months, you check the CD4 count. I told you after 6 months. If the CD4 count goes more than 350, then you can stop it. So simple. When the clotrimazole prophylaxis can be stopped. Okay, clotrimazole prophylaxis can be stopped. Now, so before going to labor, till now, before going to labor and delivery, we are going to the last part of it. But you should learn certain things where till now what we learned. Till now, initially we told the statistics and all those things. Okay. Then we told the factors influencing. See, and then we told HIV has formed, HIV, the patient has got HIV, effect of HIV on pregnancy and pregnancy on HIV, we told. Then we told that when the patient comes, staging, clinical staging, we told. Then a patient comes, how do you deal? You stage the disease, do tuberculosis, what are the screening tests, STA screening, what are things which you do, what are the tablets which you give, and these are the things which, and during the antenatal period, how do we deal with HIV? And we told that all patients, as soon as they are HIV positive, we have to start on ART. Then we told about 3 groups of drugs, NRTA, NNRTA, and protease. And very simple. All I have not taken all the drugs. It's common drugs which are anti-LE, TLE, the regime which is regime for all HIV. It is a pregnancy or whatever it is. You give it throughout the day, throughout the pregnancy, throughout, and all the patients can be given TLE. And then we learned TLE if that is previously NNRTA is being exposed, so it will become resistance. That resistance is there, then we have to change to ritonavir protease inhibitors like ritonavir, boosted lopinavir regime shall be started, and how many tablets, which are 5 tablets has to be there. Then we told about the clotrimazole prophylaxis. So these are the things which we learned. Okay. Now let us see labor and delivery. It has become very simple actually. See, previously in our time, every HIV patient used to put that universal kit and go there, and like it's like a common kit you would have seen, 𝗶𝗴ＨIG HIV delivery kit. It is not as complicated as our PPE kit. It is similar to it, but it is not so much complicated. But it is also, it's not like a jumpsuit. It's like it's a gown. It is being put, and without we cover all parts of our body with long gloves. Everything principle is the same. So, and we used to do cesarean. We never used to take vaginal delivery for HIV. Later, NACO guidelines in December 23 changed everything. So they told that LSES in HIV positive pregnancy should be performed only for obstetric indications. So we advise normal delivery, unless there is no indication, like normal, like a fetal distress or affected labor or a CPD or a cord prolapse or one thing is there, then only we will do. Otherwise, we can have a normal delivery in an HIV. So when you are asked, normal delivery can be. Previously, they used to have a question was there, if you do a cesarean, how percentage reduction, 50% reduction. But benefits of cesarean at that time, most of the people were giving ARV. They were only given Nodine. That is the reason why we used to do cesarean. So this is clearly benefit of cesarean included mostly in women who were receiving no ARV or Sudovudine alone. That is why the previous guidelines, so you have to know the latest guidelines were, it is now in your exam only one question will be asked, what is the type of delivery you prefer? It's a normal vaginal delivery unless there is an obstetric indication. Then you are going to take universal portion that you all know. Artificial growth membrane has to be avoided. Why? The reason is that vagina is full of organism. So the viral, so after it is more than 4 hours, easily it can go inside and the baby can get infected. In cervical examination, use aseptic and atraumatic techniques. Avoid invasive procedures like fetal blood sampling, fetal scalp electrode. Avoid instrumental delivery as much as possible. Low cavity, even if you want to put an instrument delivery, low cavity outlet forceps. And so it is the vendors using slipping and all these things can create injuries over the head as well as on the side. Routine cut and bleeding as possible, not do. So we try not to put an episiotomy, try. And you should not have a difficult delivery also on the other side. Then you have to be careful not only to you, you have to be careful about your assistant, house surgeon, as well as the nurse stand on the other side assisting you. So you have to use a dry hemostatic technique. So I do usually I do a cesarean in 30 minutes and comes out. But when you are doing an HIV infection, HIV patient, I may take 1 hour. So is RBC, it is held so judiciously. and I will not rupture them immediately after opening the slowly let the baby out, then rupture the membrane slowly, because it will not splash all over. So all these things, and to be early cord clamping, you know that the blood, minimum blood early comes out, immediately clamps the cord, that it is use of round tipped blunt needles. So you should understand that pointed needles can injure you and your assistants. Do not use, never use, this is a dictum you should learn, never use with your hand and hold the needles up. So it can easily injure and touch and injure you. Sterilization of the instruments and OT, it is very simple now. They will ask you what is the solution used. Please, all of you, sodium hypochlorite solution. Sodium hypochlorite solution is used to sterilize it. Autoclave your instruments, that is different. So sterilization of the OT and all, we clean it with the sodium. This is the same thing that is used for cleaning the OT after a COVID surgery also, or a COVID delivery also. So in your exams, use sodium hypochlorite solution. Now coming to care of an infant. Okay. Last part, you have delivered mother, everything, your infant. See, here also, in the olden days, you know that breastfeeding can cause transfer. Okay. But we learned that if the patient is on ART, it is a chance will be reduced to 1 to 2%. So what is the not giving breastfeed? Why do you want to say that? Not to, you have to give breastfeeding. So we encourage exclusive breastfeeding at least for 6 months, preferably 6 months. So otherwise, exclusive replacement feeding. So either one, exclusive breastfeeding is what is encouraged. Exclusive replacement feeding only if the mother has dead and terminal illness and decide not to breastfeed despite of adequate counseling. So the exclusive replacement feeding, AFAS, it's called the another question which is asked. AFAS. AFASS. Affordable, feasible, acceptable, sustainable, safe. Or sometimes they write AAFSS. So whatever way you want to write, you can write. But AFAS is what you learn. So when you get reading practice in HIV, you say in an exam AFAS, and that is enough. The examiner knows that you know what it is, and you tell that, like you told normal delivery, one word, normal delivery. Here you say exclusive breastfeeding. So breastfeeding is what? If the mother or some problem is there, you give exclusive replacement feeding. No mixed feeding should be encouraged. So in India, we encourage exclusive breastfeeding. You know that this is very costly and it cannot afford. And the children, you can see the status of India, poor country like India. So as I told you, breastfeeding should not be stopped abruptly. No mixed feeding is there. So you cannot have replacement feeding and breastfeeding together. What we do is that you start complementary feeding. So the baby will be having whatever things baby can be given slowly, baby, other things has to be introduced into the baby's food. The breastfeeding continued up to 1 year. Infant tested negative, that's enough. Continued up to 1 year. If the infant is tested positive, then what is the use of taking the baby away? So you give breastfeeding for 2 years so that at least anyway baby has become positive. Nothing more is going to happen. So at least baby will get nutrition through the breast milk. So I told you here it is very simple. For infant, only one treatment, 𝗵𝗴𝗯𝗶𝗃 prophylaxis. So not treatment actually, don't say treatment. Treatment is entirely different. I'm not going to discuss about the treatment of a HIV positive infant. I am only concerned to stop parent to child transmission. So all the babies delivered of an HIV mother is given 𝗵𝗴𝗯𝗶𝗃 prophylaxis for how many weeks? 6 weeks. So 6 weeks, small thing, 6 weeks. And if you are asked, it is 2 milligram per kilogram. 2 milligram per kilogram, 𝗵𝗴𝗯𝗶𝗃 is given. At least you remember like that. It is slightly different. Like for example, if the infant is less than 200 grams, 2 milligram per kilogram. If it is between 2000 and 2500, 10 milligram once daily you are giving. If it is more, 15 milligram once daily. If you calculate also 2 milligram per kilogram, you get all these things. So it can be given oral tablets or a ml syrup you can give on. So the duration you should understand is that up to 6 weeks, irrespective of whether exclusive breastfeeding or replacement feeding, whatever you give, see up to 6 weeks, irrespective of whether the exclusively breastfeed or exclusive replacement feed, may be extended to 12 weeks if the mother was not received ARV for adequate duration, that means 24 weeks were. That is means mother should have received ARV for at least 24 weeks. Okay, then you give only nevirapine for the baby for 6 weeks. If the mother is diagnosed HIV only at 32 weeks, then how can you say? Then you have to give nevirapine for 12 weeks to the baby. That is about 3 months, 1.5 months and 3 months. That is what is only in effect. Then you leave it. Then what you do? To do reinforcement with AB if after first 6 months. So I told you it has extent, and the diagnosis you have to do the testing at 6 weeks, 6 months, and 18 months. This is another question which is asked. In an infant which are and 18 months it is negative, we say it is negative. Do all immunization. Then coming to clotrimazole prophylaxis. Do initiation and continue till 18 months, where till baby is told negative. Longer if the baby positive, then you continue clotrimazole prophylaxis for a long time. Okay. Do not stop nevirapine prophylaxis 6. That is what we told. Mother has not taken adequately, then it has to be continued for 12 weeks. These are the points. So what are the points? 5 don'ts. Do reinforcement. Exclusive breastfeeding should be encouraged. Diagnosis should be done. Testing should be done 6 weeks, 6 months and 12 months. All immunization should be given. Third point. Clotrimazole prophylaxis until baby is 18 months. You can continue if the baby has become positive. And do not stop nevirapine prophylaxis for 6 weeks only. 6 weeks only is needed. But if the baby patient has adequately not taken, then you have to continue till 12 weeks. Okay. Now this is what we told. It is simple. The clotrimazole counseling, whatever we have told, I have made it into immunization has to be done and all these things. So you remember that 5 points is more than enough. Now coming to contraception part of it. So you have to, after delivery, you have to say about contraception. See, protection against unplanned, it will help in protecting unplanned pregnancy as well as HIV. So what you have to use condom, plus you can have any other method. Okay, so an emergency contraception tablet can be used along with condom. Hormonal contraceptives like pill, patch, everything can be used. Even IUCD can be used. There is nothing, no contraindication. Even DMPA injectables can be used, but they have not significant interaction with DMPA and antiretroviral therapy. Okay, now ritonavir boosted regimes, lopinavir regime. OCP is contraindicated. They know that it's a contraindication. Why you told? So you have liver damage and all these things. So you give again OCP over it. It's contraindicated. Nevirapine reduces the levels of OCP. But at present, this dosage, thinking that don't increase the dosage of OCP, taking 2 tablets of no benefit. Now we have not gone to that. And always the best is the male partner. Counsel the male partner to do a non-scalpel vasectomy. And condom, and you all know that even if a scalpectomy at least up to 3 months, you have to use double protection. Better to use condom continuously. That is what if it's a HIV patient. Counseling postpartum. See, you have to tell that you have to continue ART. So many people has a habit that after delivery and all these things, child is negative, they stop ART, and you have to counsel them properly. As Sarah has told, they have to leave for the baby. So if they stop it, their disease will fast, it will go. So they have to be counseled to take ART. See, I have patients, HIV patients who have 2 children. After one child HIV positive, then again they came and they are living happily actually. They are taking, but they are all taking, and both the babies are HIV negative because both cases they had taken ART, exclusive ART very well. So they don't have any problem at all. They are living a normal life. Children are having a normal life. Okay. Support of the husband, infant prophylaxis supply, immunization of the baby, insertion of copper T can be done. Copper T can be done 2 ways. Nowadays, something called you can put the copper T. Placental means immediately after delivery, you can put the copper T and send the patient. IUCD it is called. Postpartum IUCD it is called. Otherwise, after 6 weeks, you can put a copper T and use a condom. So double protection, non-scalpel vasectomy for the male partner. Last one point I wanted to highlight. Actually, sorry that I am taking time. Last one point which I have to highlight is that HIV in pregnancy with active tuberculosis. Tuberculosis is responsible for 25% of death of HIV individuals, whatever it is, pregnant or non-pregnant. Risk of active TB 10 times higher in HIV. Okay, very important. Active tuberculosis in HIV infected pregnant, maternal mortality increases prematurity increases, low birth weight is there, infant tuberculosis, and the risk of HIV transmission is 2.5 times increase. That is the reason why it has to be treated very efficiently. So the evaluation, that is why I told you tuberculosis will be screened. So every patient, we take the history, we have to see screen for tuberculosis. Should be started on ART irrespective of, so every patient should be started HRT, ART irrespective of CD4 count. ATT should be started first and followed by ART as soon as feasible. That is what how usually after. So first they will ask you in an exam. So tuberculosis at HIV, first in pregnant lady, what will you start? First we start ATT, then after 2 weeks we start ART. That is what, not ART and then ATT. ATT will be more important because we have to, the danger is tuberculosis exacerbating during in pregnancy. Drug interactions have, see, these are all questions which are asked, is called, see, 𝗶𝗴𝗯𝗶 is preferred over, we are giving only 𝗶𝗴𝗯𝗶, 𝗔𝗐 regime only we are giving. Those who cannot tolerate EFV, we will not give nevirapine. What we give is called ritonavir, lopinavir boosted, ritonavir boosted, lopinavir regime, like inhibitors. So rifampicin is a component of ATT, should be substituted with rifampicin. So the efficiency of the drug rifampicin is decreased by ART. So that is why rifampicin should not be given. You have to give in all. So that is another question what is asked. Rifampicin is not given. HIV tuberculosis, the rifampicin is replaced by rifampicin. Please, all of you, these are all not only all for at your level, your exam questions as well as your PG entrance questions. Now coming to what are the 4 prongs of prevention of parent to child transmission. Primary prevention of HIV, that is prong 1. Prong 2 is prevent unintended pregnancy. Prong, see, first you remember, say patient is an adolescent coming for adolescent counseling. That is what is called the primary prevention of HIV. A counsel about it. You have to family planning counseling. That is what is called prevent unintended pregnancies. Third is that patient has become pregnant. So our aim is to prevent mother to child transmission. Fourth is that you have to give care and support and treatment. That is the 4th prong. So they will ask you what are the 4 prongs of PPTs. Today's class, today's that lecture, these are the things which you will. So what are the 4 prongs? So entrance they will ask, these are the 4 prongs except. So it's a primary prevention of HIV, prevent unintended pregnancies, and prevention of, this is what. Primary prevention, all these things have been discussed actually. Safe sex counseling, couple counseling. Sir has told so well actually. I also enjoyed the talk by Dr. Kiran. Linkages of family planning services, free condom, behavioral communication, repeat HIV, consenting the window. But all these things are infant feeding and whatever counseling you, all this counseling has to be done. Then the patient has become, these are the last slide actually. So what are things that has been done here? It's an antenatal care, ensure that there is a 4 visits. All these things are done in the PPTCT. So counseling of nutrition, proper screening for tuberculosis, screening for a CD4 testing, WHO clinical staging, counseling positive, then counseling safe sex, linkage to ART services. You send the patient, provide ART the most important sentence of the day. Provide ART regardless of clinical stage and CD4 count. Nutrition counseling, linkage to government and other family planning services, breastfeeding, psychosocial support. So these are the things which we learned. Coming to the last slide of the day. So what we learned here, see, you can see here, pregnant woman or a breastfeeding woman with HIV, lifelong ART, TLE, again TLE. Today you learn TLE, that is more than enough. So you have to do a CD4 baseline, but do not withhold ART while waiting for the review. Start ART. You take baseline, let the result come, and ART initiation to be done only at ART center. So we send the patient to the ART center. Delivered baby, we all know exclusive breastfeeding is what, or exclusive replacement, mixed feeding we don't allow. So whatever it is, we say that nevirapine for 6 weeks, nevirapine for 6 weeks. Other, it is a EBV or ERV. So EBV, it is exclusive breastfeeding is EBV, and this is the other exclusive replacement, EBF and ERF. So, and the patient diagnosed at 6 weeks, then we'll ask you 6 weeks, months is optional, we say 18 months. Okay. At the final diagnosis, 18 months, 3 rapid tests are done, and finally we diagnose and engage to ART center. This is what is finally what is being told. So certain points in the second part we told, you should remember certain points when it comes to labor, normal delivery. One word each. Infant, exclusive breastfeeding, 𝗶𝗴𝗯𝗶𝗃. Okay, simple. Labor also, whatever TLE was continued, you continue the TLE. Okay, then you have to, for the infant, 6 months, 6 weeks, 6 months, and 18 months. And 18 months you test and say that the infant, all the tests are, 3 tests are negative, and 3 rapid. Okay, we say that, okay, now the patient is HIV negative. So then told about that 𝗏𝗏 prophylaxis, please remember. In the mother, continuously after 6 months we do CD4 count, it's more than 350, then we stop. In the baby, when it is go, you have to start till 18 months, you have to give 𝗏𝗏 prophylaxis. Even if HIV, then HIV positive, you continue. HIV negative, you can stop 𝗏𝗏 prophylaxis also. And 𝗶𝗴𝗯𝗶, 2 mg/kg body weight, you remember, and it is given only till 6 weeks, and then you stop. Then only you monitor the patient. These are some of the things which I wanted. And you remember that 4 prongs, what will you remember? That one is an early, then another is a 1 by 1, then is becoming married, so she should unintended pregnancies and all these things, family planning counseling, and then comes a mother. So preventing, how to prevent PT, that parent to child transmission. Okay, and finally when the patient is positive, and care and to the given to the baby. So thank you. I know that it was a long lecture, but Gauri wanted it to give me cover all the points. That is the reason why. Hello. Hello.
Yes, sir.
Gauri, you are there? Yes, Kiran. Kiran is Dr. Kiran is
Yes,
there.
sir.
Also
Yes,
there.
sir.
Is also there.
Thank you, sir.
Okay. Hi, Dr. Kiran. Hi. So nice. Anyway, it was a nice. Thank you once again to all of you for inviting. Hey. So I know that it was little exclusive, especially Gauri. Are you satisfied with what I covered? Yes, gone, I think.
Yes, sir. Very much, sir.
She wanted, I told initially that I will be only covering the HIV in pregnant. See, she told a little more they want, as because we don't have a physician as such to cover the clinical part. So I whatever I could from the gynecology point of view, whatever knowledge I have, I am not a physician to cover the whole thing knowledge, but whatever I have told you. Okay.
Thank you, sir.
Thank you.
Sir, we have from behalf of the student community. Thank you, sir.
Thank you.
So, sir, our fellow students, we have like a few doubts. Please spend a little bit of time to share your valuable experience with us. Maya, ma'am.
Yes.
Could you share your opinion on like what is the greatest set of challenges that India faces today in tackling AIDS? Could you shed some light on that matter?
Okay, I'll tell you. That is the positive part of that question is that, as you all know, the NACO it started ICTC centers all over India. And since India is the second populated country in the world, and we could achieve, the steps that is taken by the NACO to the lowest of the community. Okay, so many awareness programs, so many classes we are conducting. And so from 2010 years back, we are coming up to 2020, and we have reduced so much of cases all these years. So that is all the positive steps that is taken. Wonderful job by the NACO and all the ICTC all over the country. And the challenging part is that you all know that in our ICTC, we are doing the antibody test. Okay, so when a patient comes during the window period, that means it is very difficult to test the patient, that is to test the antibody during the window period. So that is the main challenge I feel right now, because the antigen kits are available, but it is not cost effective. So it should be made effective, the antigen kits. It should be cheap and it should be available in all our ICTC in the government sector, so we can diagnose the HIV during the window period. So that is a main challenge I am feeling right now, because so many cases are we have been missing in the window period when we do this rapid test in the ICTC, because I told you we are detecting the antibody. So that is a main challenge that we are facing. No, otherwise it's well and good. We are conducting so many programs in ICTC level and also in the government sector level. We are conducting so many programs, and the patients, or the society is aware of the situation. What Dr. Kiran and Dr. that Ashwin said, and we are far ahead. Okay, so that is the answer for that question.
Thank you, ma'am. Thank you for sharing your valuable experience and opinion with us. To Dr. Arun sir, sir, students have been asking, like in the wards, there will be AIDS patients will be admitted in the ward. So how can we prevent the stigmatized attitude of people and other patients to AIDS patients who are admitted in the ward? How can we prevent such circumstances? Is there any way to do it?
So you mean the question is like, if a patient is admitted in the ward with HIV positive, how to prevent the stigma?
Yes.
Okay. So basically the question will be, I will be asking you another question, like how will the people around know that he is HIV positive? Huh? Like how will he know that, how will the people around will know that he is HIV positive? It happens, yeah, it happens. But let me tell you something, like in, basically the confidentiality part is very, 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 very important. Okay, when you are handling a diagnosis of HIV, the confidentiality part is important. If somebody around knows from your way of handling the case, if somebody around knows and the patient may later, complain about you or anybody who became a part in the breach of confidentiality, it may even be taken as a crime. Okay. So that's where I said, like, it's a big, confidentiality is a big issue. Now let's imagine if somebody, the people around knew that the person is positive and they are actually showing a big kind of stigma and all. The ideal thing will be for you is to contact, in such a situation, it's like a kind of a crisis situation, because the patient has to stay there and get the treatment, and you cannot, ask him to discharge, or transferring him to other ward and all will be very bad. When if that happens, it's a big psychological trauma for the patient. So you may have to do some sort of one-to-one counseling first. Second, you may have to deal with the stigma in the ward with some educational programs or some, like group teachings and all, some role play videos. And also your way of handling the case will also be important, because as doctors and health workers, we have to be a model in front of the patient and the people around that we do all that. Okay, we do all that, and there is no harm in that. So that's where I said, even us students have difficulty in approaching a HIV positive patient. Okay, even us students or as doctors, we have difficulty in approaching an HIV positive patient, because our behavioral change is not up to the emotional level. Okay, we are still on the core. We are actually a bit afraid, like what if we get it? Because we know intellectually that we will not get it. If we follow the procedures and all, we will not get it. But on the emotional basis, we are not sure we will get it or not, because we have an innate fear that we may get it. It's just like the COVID scenario. Okay, people who are not yet exposed to the COVID wards still are afraid that they may get the COVID, they may get the COVID, they may get the COVID. But those who are actually in the ward working day and night are actually like almost like, they're not that worried. They still go back, they still play with the children, they do everything, and they still work in the COVID. So that is called an emotional change in behavior. Okay, where the person knows that what all is to be done and they do that. Okay, so first thing for students, they have to get their posting directly and deal with this patient, so that they get this exposure and readiness to deal with the patient. And now, to reduce the stigma in the ward, the ideal thing will be the way you first change the way you deal with the patient, the way you behave with the patient, whether you touch the patient, how much time you spend with the patient, how much precaution you actually take, when are you using too much of precaution so that it becomes a big, scene for everybody around. There was a time when in surgery wards and all, I'm not talking about HIV, it's just HCV, like hepatitis C. We have to put 2 gloves. Okay, there was a time when I practiced, we have to put 2 gloves before taking blood sample from the patient. So, house surgeon or like the doctor itself, let's say the doctor itself, he is taking blood from each place, and when he came to this particular patient, he actually took another gloves also and put it. And this he did in front of everyone. Okay, in front of every other people, and they were actually looking. For this patient, he's using 2 gloves, but for other people, he's using only 1 gloves. Okay, now see how the stigma develops. So you have to make sure that your behavior becomes a model for everyone else. Okay, in that case, when people watch that, slowly by modeling, the fear decreases. Second, the patient feels good. Patient feels like you are a friend, and his behavior also will not become irrational, and slowly the stigma may come down. Okay, but education in such a crisis, you need a mass education in the department itself. But at that, in such a situation, you can better contact the ICTC centers. They will send somebody expert to deal with that and all. Okay, but confidentiality must be ensured. Okay.
Okay, thank you, sir. Thank you for sharing a valuable experience with us, sir. Now, to choose, sir, the students have been asking, like, if, in some situations, that maybe due to the social stigmas or maybe due to the disease progression, some of the patients have lost their hope. So, how do you deal with such patients?
Once more, you tell the question once more, please.
Sir, some of the AIDS patients, maybe due to the disease progression.
Due to disease progression, then.
Or maybe due to social stigmas, they feel that they have lost their hope. How do you deal with such patients? Now, is there any new treatment? Sir, you have spoken about HIV-1 and treatment for HIV-1 and HIV-2. Is there any new treatment that can be taken as a last?
See, this is whatever I have told. These are the new treatment. But the question actually, what you are asked, should go to Dr. Kiran. Actually, the thing is that if the patient has lost hope, see, we have to counsel. Basically, whatever he has told, it's a counseling that is what is the most important. See, you don't allow that patient to go to, and you give good examples like what I told. Patient living with years with HIV. So that is the only way you can deal with it. There is nothing like you should not allow the patient to lose hope. Once he loses hope, he or she loses hope, he will not be taking regular treatment. Then the disease progression will be very fast. So that social stigma and all these things, now you can say that name some big personalities who are living with AIDS and all these things. They opened we know that. So we used to say at that time, Michael Jordan, those who had been the big tennis players, big like that, who are been with living with AIDS and all these things, some examples to show them that they are open and they are living with AIDS. So you can live with AIDS because it's just like a diabetes. You can, if you take proper treatment, you can leave. That hope has to be given. Once the hope goes, no use. That is all the. So what we do is that we take our Kiran's friends, all our psychiatry department is very good actually. So almost all the patients with HIV, pregnant patients, are having psychiatric counseling. So not that psychiatric counseling, they are sent to the specific psychiatrist. They will talk to them for 1 hour. That gives them some, because you have to, these patients, you all students should understand that how many busy you are. Such a patient comes to you, you have to spend time with this patient. So that is the only reason, that confidence which you have to keep. Okay, and the patient should have confidence in you that you will not reveal the result of the patient to anybody. So when one patient with HIV is going to delivery and coming to my, even I had doctors, HIV patient, doctor delivering in my hospital, and nobody know. Not even only the husband and wife was knowing, not even the mother-in-law and mother who was staying there. We did not allow them to stay there. We kept one of them because it was so secretly it was done. Mother was knowing. That is the only person attending was knowing. No case sheet was kept inside the room. Everything was kept locked. So nobody, we were all behaving normally. They were talking to surrounding bystanders normally. And we always try to give them one room. Actually, we don't give them in the general ward or anything. We try to provide them room, even if it's not affording patient. From our side, we say that this patient is being kept in a room. So that is what from our side what we do. Sean.
Thank you, sir. Thank you for spending your valuable time with us and sharing your experience. Now I'm handing it over to Varsha.
Thank you, Sean. We live in a completely interdependent world, which simply means we cannot escape each other. How we respond to AIDS depends in part on whether we understand this interdependence. It is not someone else's problem. This is everybody's problem, says Bill Clinton. Good evening, everyone. I'm 𝗏𝗏𝗦𝗏𝗔𝗟, and I will be delivering the vote of thanks for the evening. Health education is the first step in changing the views, behavior, and habits of people. It is only when we know how to change can we think of changing. On behalf of SIMSA Kerala and the organizing committee of Magul, I would like to thank our speakers for the evening, Dr. Maya Sudhakaran, Dr. Kiran Kumar, and Dr. Ashwath Kumar, for taking time and being with us, spreading light on a topic so relevant and important in today's world. You've shown us the bigger picture, the clinical symptoms, care and treatment, counseling and prevention of AIDS. I would also like to thank all the participants who have joined the session this evening. My gratitude to the audiovisual team and all the hosts of the event. I hope you all had a great session and I expect to see you on the next 2 days.